I thank for the opportunity. I'm going to present a 19-year-old boy who presented to me in 1988 with an unsound, painful ankylosis. At that time, he was offered two kinds of treatment. One was a excision hip with pelvic support osteotomy and a fusion of the hip. But the parents wanted to have a stable, painless hip, and hence fusion of the hip was performed in 1988. That was immediate post-op. As a young surgeon, I wanted to do a compression at the local site, so I used DHS implants, one at the level of the ilium, and used the plate for the femur, tried to compress it, and then I got the good union in 1989. After that, he disappeared from me. He came back in 2015. After 27 years later, with a fully fused hip, married, has 4 children, working in Middle East for 20 years, and came for treatment for back pain and inability to perform namaz. And his request was whether this fusion can be reversed. I will.
All right, so Vijay, let's start in the middle. Yeah. Would you reverse this?
Yes, I would. He has got back pain now. There's an indication for me to take it down. And although the surgical fusion, there are some pointers here that makes it technically, not very challenging. So you have a good neck to do your osteotomy on. So I will take down the fusion. I will do a neck osteotomy, then the usual principles of a fused hip reconstruction. I will do that, remove the plates. I will certainly offer him a hip, yeah.
All right, would anybody not try to take it down? Everyone's going to take it down. All right, Mike, do you have anything to add?
No, I mean, not really. I think the key, it's always hard to find the socket in these cases, so I think the key take home, I would tell everybody, is just use your intraoperative fluoroscopy, because you can get fooled pretty easily in where you put your socket.
Dr. Johnny?
Yeah, so this will be definitely in situ osteotomy and in situ reaming. The removal of the DHS broken screw will be slightly a challenge, but I think once we do our osteotomy, or we can remove it from here with a broken screw removal set with a core inside and take it out. And then look in the C-arm. On the femoral side, it will be a longer stem bypassing the last stress riser.
And talk to me about your choice of femoral implant. Let's start from the...
Wagner from my side. Wagner.
Because there is a big neck and we will be able to preserve the calcar. So I will go as standard uncemented stem. And towards the cup side, we should also keep ready dual mobility, because this is once again high risk situation for the dislocation. Abductor might be weak, so we may go either 36 millimeter or dual mobility. And here standard for femur, standard stem, uncemented.
I'll use a porous metal cup on the acetabular side, and I'll use an S-ROM kind of stem.
Sometimes in these surgical fusions, a trochanteric flip may be required. If I do a flip, I will go for a Wagner. If no flip, I'll go for a S-ROM.
Okay.
I would just use a regular fit and fill type stem. I think you got pretty decent metaphysis there. I think you could get away with a fit and fill type stem. Wagner would be a second option if I couldn't.
Yeah, I mean, I think the take-home point is all the implants described were ream mill or ream and broach type systems. A broach-only stem is probably not going to work well in this situation. So that's the only thing I would avoid. All right, so show us what you did.
Any preoperative workup?
I don't know. He's your patient. What do you want to do?
I examined his knee. He has got a good function.
Good.
SI joint was mobile. Good. MRA of the LS spine was done to rule out any occult disc prolapse, which may be the cause for the pain. And gluteus medius was working well clinically, and we did Faraday current response for the muscle, and which was good. So I was very concerned that whether the glutea are working or not. So they were all working.
Didn't you do the fusion?
Yes, I did.
So shouldn't you know that you buggered up the muscle, or you didn't bugger up the muscle?
No, I didn't.
20 years ago.
You didn't remember? Okay.
Yes, I do remember.
All right. No, I mean, I think the reality is almost every time I've taken down a fusion, I never did the fusion. So I think this is a unique situation where you did the fusion, and I think if you're going to do a fusion, you need to think about the takedown later, right? You shouldn't burn bridges at the time of doing the fusion. All right, so let's go.
Difficulty in extraction.
I want to ask you, what do you think was the initial diagnosis? Because that may have a bearing now. Suppose it was tuberculosis and you're doing a joint replacement now, you might be concerned about the recrudescence. So it was a unilateral disease, sacroiliac joints were normal, it was not Angst-Bond. What was the disease according to you?
I think he had a childhood sepsis of the hip, and which was treated in Children's Hospital in Egmore. And then from there onwards, he recovered and he was walking well. And slowly, his disease, he had restriction of the movement, and at one stage, he had a painful ankylosed hip.
All right, so I think, given the history and given everything you know, I don't think there's anything wrong with taking cultures, doing frozen section, and putting in a temporary device if you're concerned, right? So let's see what you got. You got 2 minutes.
So these were my concern. I used a posterolateral approach,
Okay.
exposed the plate. One screw was found to be decapitated, so shaft was removed with special tools. In the margin, I had a fracture of the subtrochanteric level. DHS plate removal weakened the GT, but it helped me to resect the neck because the exposure of the neck became better, and used a delta motion cup, 44 size, ceramic head 44, and distally fixing solution stem, 5 hours of battering for the surgeon. And the result, in the immediate post-op, we took the X-ray, and that was the result.
This is very common though, because it's impossible to get the hip reduced because it's been fused, and you keep pulling and it feels very tight, and then as soon as it stretches out, it dislocates a day or two later. So I don't think you did anything wrong necessarily. So
What would be the cost?
How does anybody want to handle this? What's the next step?
for me, I'd get a CT scan just to make sure components are appropriately inverted and aligned. If it is, does this cup, I'm unfamiliar with this cup. Do they have a constraint liner or dual mobility with this? No constraint liner? I mean, I'd try to add length if you can, but if it doesn't have a constraint liner, you might need to change the cup.
Well, you dislocated day 2 also. I mean...
No, that's what I'm saying. If you I'd go back and put add more length to the neck and see if you can get...
What if you just reduce them and put them in a brace or a cast?
If it's, you can try it, but the ones that I've seen that dislocate in the hospital, they will continue to come back out.
I think it depends where they're coming out too. If it's coming out the front, you can put them in a brace and keep their hip flexed, and they won't come out the front. The reason why they come out the front is because they lie straight down and the leg falls out and it comes out the front that way.
Yeah.
So a posterior dislocation with a posterior approach, I agree after day 2.
Yeah.
But an anterior one, you can usually treat non-operatively.
Now, with such a big head, if it comes out, I think there must be an underlying reason. I do CT scans to assess both my femoral component version as well as my acetabular component version. And did you?
All right,
then
so
I would.
quickly, you had 10 seconds. What'd you do?
I took the patient inside and I opened up. I found that the femoral stem was loose, rotationally unstable, which is the reason why it came off.
Okay. Well, that's...
We have already spent a lot of money, so I packed the femoral canal with cancerous allografts, got a good fit, and hip was reduced and found to be stable.
Say what? Okay.
Amar, I have a comment.
Yeah.
If he had put in an SROM, he could have adjusted the version. If the reduction was too tight, he could have shortened the femur.
Yeah.
So there were a lot of advantages to using a stem like that in the first place.
I agree. All right. So did you get him a good hip? What's the follow-up?
Follow-up. The hip remained stable, but drainage was lots. So culture was negative for organism. So I couldn't find out any cause. I felt the allograft may be causing the reason. So revised the stem. And
So
that was the...
You took out all the allograft then?
Allograft.
You put in a
and
bigger stem?
Yes, bigger stem, which could...
So wasn't that more expensive than doing that the first time?
Yes.
Okay, that's
but
fine.
that is my hospital, so I can manage.
All right.
So there is 10th post-operative day. This is 6 months post-op. This is 18 months post-op. That is his function.
Good.
And he wanted to do the namaz, so which he could do now.
Good. All right, good job.
Great.
Thank you.